House Bill 2751, authorizing the Kansas Department of Aging and Disability Services to condition or restrict a disability service provider license. And we'll hear from our reviser, Jenna Moyer.
There we go. Good afternoon, committee. Thank you, Madam Chair. Jenna Moyer, Reviser Statutes Office. House Bill 2751 relates to licensure providers of disability service within the Department of Aging and Disability Services. It amends two sections of law. Section 1 amends KSA 39/2004, and it adds a provision in subsection C that would allow the Secretary to waive a requirement of rules and regulations adopted under this act if that regulatory requirement is in the public interest and will not detrimentally affect the life, safety, health, or welfare of any person receiving care or treatment in a center, facility, or hospital that is licensed under the act. And section 2 amends KSA 39/2016, and that would allow correction orders that are issued by the department. In that notice of assessment, the department would be required to advise the licensee of their opportunity to be heard, as well as to appeal that order, that correction order, in accordance with the Administrative Procedure Act. I'll be happy to answer questions.
Committee, is there questions for Reviser Moyer? All right, seeing none, thank you very much. I appreciate it. All right, committee, the first proponent we have on the bill is Lacey Hunter, Commissioner, Survey, Certification, and Credentialing, Kansas Department of Aging and Disabilities. Welcome to committee. Good to see you again.
Good afternoon, committee. Thank you, Madam Chair. My name is Lacey Hunter. I am the Commissioner of Survey and Certification for KDADS. Thank you for this opportunity to present proponent testimony on House Bill 2571 today. This is a bill that our department requested be introduced during this session. It addresses the gap in authority that the Secretary of KDADS has under the Kansas Administrative Procedure Acts, and is part of our agency's regulatory authority. One of the things that I do and I oversee within my commission is the licensure of quite a bit of facilities and or people. One of those things that I was brought on to do is the crisis intervention centers. When we were working with the Attorney General's office during that process, they pointed out a few things to our agency. Some of the things that they pointed out to us is that our agency lacks the legal remedies within our licensing statutes that most licensing agencies have. And our legal remedies don't connect to the Kansas Administrative Procedures Act, and the appeals do not follow through the Kansas Judicial Review Act. A lot of other state agencies have authorizing statutes that clearly reference both of those for both the procedural authority, and this would make the procedure consistent across state agencies. The other thing that it would allow is for us to put restrictions on a license. Both of these things would make it so that KDADS would not have to go to or take someone to court in order for these things to be enacted. As it stands now, if I wanted to place a directed plan of correction on a provider who was maybe poorly performing or needed a little bit of direction, if I wanted to truly make them do it, I would have to take them to a court of law as it sits right now. The bill itself, I do apologize. I have 3 sections of law that we're going to go through today, but I'm going to kind of try and break it down for you on what we're doing here today. So in House Bill 2571, KDADS is requesting to add amendments to add the ability to place a condition or restriction on a license. I have that as amending KSA 39/2013 in Section 2A of the bill. The next section that we're going to discuss is adding the Secretary's authority to waive a regulation requirement when the health, safety, or welfare is not being jeopardized by the waiver. I have that as KSA 39/2004 in Section 1C of the bill. And then the last thing that this bill would do would be asking or clarifying that the CAPA and the KJRA process apply for all remedies. And I have that in the bill as Section 3B in KSA 39/2016. KDADS is seeking waiver authority in line with other agencies. The Secretary's waiver authority exists in some sets of our regulations that were transferred from KDHE as well as Social and Rehabilitative Services under the Executive Reorganization 41. In those regulations, the Secretary can waive a regulatory requirement, such as an environmental standard, when the Secretary determines that the health, safety, and welfare of the resident or the client being served is not in jeopardy. The Secretary's authority to waive the requirement must be granted by the Legislature to allow reasonable waivers from regulatory requirements that prevent unreasonable cost or burden without imposing health, safety, or welfare concerns for the resident. House Bill 2571 cleans up the language from previous agency reorganizations that had that waiver authority, and it allows for the agency reorganizations that impacted the statutory authority to be provided to KDADS and the Secretary of KDADS. The last part of 2571 is reviewing all the rules and regulations as part of the 5-year cycle. One of the things that was done is through House Bill 2087 in 2022. It will require for KDADS as well as other agencies to review every 5 years under KSA 77-440 and then revoke under KSA 77-426. KDADS will be reviewing all of its rules and regulations as part of that cycle during the next calendar year. Making the statutory changes in House Bill 2571 will clarify the regulatory authority and align agency procedures with the CAPA and KJRA before that review process starts. KDADS anticipates the statutory authority clarifications in House Bill 2571 will help avoid delays in the review or additional regulation updates by aligning to the standard practices used by other agencies and clarifying the Secretary of KDADS as authority. I would also like to make mention of some amendments that we have been told might be coming towards this bill that would align with some stuff with goodwill. And we would just like to add that we find that to be friendly amendment language and would support it. Thank you for the opportunity to provide supportive testimony on House Bill 2571. I'm happy to stand for questions.
All right, thank you. Sorry about that. Committee, are there questions?
Bueller.
Representative Bueller.
Yeah, thank you, Madam Chair. I'm kind of struggling with all of the changes. Could you give me like one or two examples of this is the reason why we're doing it, or kind of real world examples of how this would be a benefit?
Absolutely.
Thank you.
So one of the things that it allows, so placing a restriction or a condition on a license, and then us being allowed to enforce that condition or restriction without having to take them to court in order to do that. So an example of that, a lot of times when we see a licensed provider who's maybe struggling with telling us how they're going to correct their deficient practices, one of the options that we have is to do a directed plan of correction, which is where we say, as the licensing agency, here's what we think you need to do. You must execute XYZ in this time frame in order to come back into compliance with the regulations required to hold a license. In order for me to have any meat to that and say you actually have to do this, I would have to take them to court right now to do that. The only thing I have the ability to do without taking them to court is saying, I can take your license away. I don't want to go straight to that. I would rather work with providers, give them those steps in between, work with them to get better. I do think that at some point there is sometimes the necessary means to have to take the license, but I don't think that has to be the step right away if that's the only authority I have to do in-house, so to speak.
Representative Clifford.
Thank you, Madam Chair. In your second paragraph, you talk about the trigger for this was trying to implement regulations for crisis intervention centers, but am I to understand that this applies to all entities over which you provide licensure and supervision?
Yeah, so KSA 39-2001 is what I like to call my licensure act. That is where I find authority to license IDD day and residential providers, as well as psychiatric residential treatment facilities, private psychiatric hospitals. I'm missing some. Residential care facilities, crisis intervention centers. I think I got them all now.
Surgery centers?
No, I do not believe that was contained in there.
So all of those things you mentioned come under this?
Yes.
Okay, thank you. Thank you, Madam Chair.
Representative Epley.
Thank you, Madam Chair, and thank you, Lacey, for being here. I just want to make sure I got this right in your testimony. The amendment language that you're referring to is in the current bill, or are you proposing that we add language to the concepts that you presented to us?
It is my understanding that the proposed amendment language did not meet the cut for this today, but it is my understanding that there would be some amendment language coming soon. From, I think Representative Carpenter and Goodwill had been talking about making some proposed amendments to this section that would help with background checks. Maybe I'm speaking too soon.
And again, not to go over all your testimony again, there were 3 areas of amendment that you thought needed to be addressed and that are not codified in the current bill. I just want to make sure that the committee is clear on that.
Correct, correct. There are.
And those are just brief, very brief bullets on those 3 areas are what, 1, 2, 3?
Yep, so 39, 2013, it talks about the ability to put a restriction on a license. 39, 2004 talks about giving the secretary the ability to waive a regulation when health, safety, and welfare is not in play. And then 39, 2016 clarifies the CAPA and the KJRA process for our remedies.
Okay, thank you. Thank you, Madam Chair.
Representative Barth.
Thank you, Madam Chair. And I'm really glad that Vice Chair Epley brought that up, because I actually was pretty confused when you were talking about the legal language and everything. So that helps clarify it, but it actually probably muddies the waters for what the bill's intent is for. On the original, what's in here that we're looking at today. Representative Buehler asked a question which didn't fully understand. I don't think what you answered really fully clarifies for me. You've talked a little bit about who's making the restrictions today, but you never said who is doing that. And so there's some gaps in what you're talking about that's not 100% clear. If you could go back to what you said and clarify that, please.
Sure. So as it sits today, all the providers that I listed, they're responsible for getting a license. Typically, it's from my commission specifically. In order to keep that license, you must maintain the minimum requirements or the regulations that apply for keeping that license. When a facility cannot maintain those minimum requirements, so say my staff goes out on survey, they survey the facility to see if they can get their license renewed or their current license can stay intact because of a complaint. The way it sits right now, if we wanted to provide that facility with a remedy such as, here's what we think you need to do, here's some people we think might be able to help, we're not really able to do that currently. We can tell them that's what we'd like you to do, but if they come back and say, make me, I have to go to a court and tell the court, say, hey, I really need you to make them do what I asked so that they can get better.
Representative Orpeza.
Thank you, Madam Chair. I had questions in regards to what Representative Epley had said. You had 3 points. Can you give an example of point 2 and 3 of how this is fixing?
Okay, so the ability to waive, so I say one is the ability to place the condition or restriction.
Correct.
So second one being ability to waive the authority. An example of when I find that to be important is in particularly physical environment. Sometimes there are situations where maybe the residence itself doesn't quite meet what the box cookie cutter regulation says it must. Maybe there is something like, here's a good one. In an IDD home, a lot of times you have situations where people who turn 18, they are phasing off of a foster care situation and into an adult IDD situation. They might have brothers or sisters or fellow people who live in the house who are not of the same age as them, and they're not aging at the same time. Giving the secretary the ability to waive the requirement that you can't have both a foster care license and an IDD residential license from us would allow allow for those cases where we can review that specific scenario, work with the provider and say, we can waive the requirement that says you can't have both of these licenses right now because we understand the situation and the kids that you're caring for and as they're turning into adults and keeping everyone in their service model together.
Okay, and then there was a third?
Yes.
Portion?
So the third one was, so if we were to apply a remedy, so we wanted to say a directed plan of correction, we wanted to tell you something that you needed to do because you weren't able to meet the minimum requirements. What the third point is it would make it so that the process for enforcing what we said we wanted you to do followed what many other agencies do, which is the Kansas, oops, sorry, I'm not gonna say it right if I don't go back and reference it. The Kansas Administrative Procedures Act, and then the Kansas Judicial Review Act. And both of those then, within those acts is where you kind of find the authority and the ability to process those remedies within your agency and not having to go to administrative court in order for those remedies to be enforced.
Okay, thank you.
Committee, are there further questions? All right, seeing none, thank you very much. I appreciate it. Next committee, I have Chris Stanner, Chief Mission Officer, Goodwill Industries of Kansas. Welcome to committee, Chris.
Thank you, Madam Chair, members of the committee. So Chris Stanner, Goodwill Industries of Kansas, and I'm here today to stand in support of Bill 2751 as written. Goodwill Industries, just to lay a little background, we're a 501c3 with retail stores, and we use those retail dollars to further our mission. And part of our mission work is working with individuals with intellectual and developmental disabilities. And we have roughly 130 individuals that we serve in day services and roughly 180 individuals that we serve in case management. And historically, most of those services have been in the Wichita area, and we're looking to move those services and expand them outward into other parts of Kansas, specifically where we have our retail stores. Integrated employment is a very important part of providing those services, getting individuals out into a work environment so they can work with what we call a direct support provider as an individual that works alongside them in a real environment, real work environment to help teach those skills. And we've had some unintentional restrictions that have come through KSA statute 39-2009 to where we really were facing suspending our day services at our Newton retail location and our Hutchinson retail location based on the language in that statute that says our entire agency would need to complete and pass background checks and undergo the full KDADS training that's specific to working with our day services program. The difficulty for us is that we're a second chance employer, so we do work with individuals who need a second chance in getting started, and we have close to 700 individuals in our agency statewide. So it's very difficult for us to be able to meet that criteria in order to satisfy the KSA requirement so we can provide services to individuals who need this work. Additionally, we're seeing a push of additional funding, which we greatly appreciate, that's come from the legislative body to be able to reduce the waiting list for individuals that can receive these services. Right now, it takes 10 years from the time you apply to the time you're able to receive any kind of services at all. And I've been watching the legislative body work very hard to try to reduce that time. In order to reduce that wait list, not only does the funding need to be available, but we also have to have the infrastructure to support it. So we need to have the providers. And that's one of the reasons why we're looking to expand our services into other communities. So again, standing in support of 2751, but I would strongly encourage looking at KSA 39-2009 for possible revision. Now, we have been working with the revisor's office through Representative Will Carpenter, to put together some language for this, and we've been working with the legislative team at KDADS as well, and we feel like we formulated some language that really works all the way around. It redefines, or adds actually, to the definition of a provider of services without impacting any other part of the legislation. And I greatly appreciate Commissioner Hunter and her team for working with us to try to solve this issue, as I think we all have the same goal in mind. It's my understanding that that language is going to come out of committee tomorrow at the House Federal and State Affairs Committee. But I wanted to make sure to mention it here in case it made more sense to wrap it into the work that's being done through this committee. And it's a little above my pay grade, but I wanted to introduce it, let you know that that work is being done, and it would solve a problem for us. So I'll be happy to stand for questions, Madam Chair.
Committee questions? Representative Orpeza.
Okay, so if thank you, Madam Chair. If I'm understanding this correct, there is an amendment, but not for this bill that we're seeing here, but in federal state affairs? Is that correct?
Yeah, so it is. So all of this kind of came together at the last minute as we were making frantic phone calls on Friday, trying to figure out, okay, we've decided on our language, but how are we going to introduce this language? What's going to be the best way to do that? And I wasn't familiar that this committee was coming together until really on Thursday, and I thought, oh shoot, I wanted to make sure that you were aware of that language. But right now, it's something that we've developed with Representative Carpenter, and the plan was to go ahead and introduce that through the House Federal and State Affairs Committee tomorrow. But Representative Carpenter, who chairs that committee, is aware that we are presenting this information today.
Okay, thank you.
Committee, further questions? Representative Epley.
Thank you, Madam Chair. And again, Chris, thanks for being here and probably confusing me more than I already was. And that's okay. I think others are confused a little bit too.
Sure.
Are you in full agreement with the wording changes proposed by our first proponent, Ms. Hunter, and the amendments that she, or would that change your position as far as being a proponent if the amendments that she mentioned go on this bill?
I'm in support of the amendments that Commissioner Hunter is proposing as written. I think it's very much a step in the right direction. But I simply wanted you to be aware of the additional language that could help refine it even further.
Okay, thank you. Thank you,
Thank
Madam
you.
Chair.
And I think Representative, and Lacey, you can give me a nod or whatever, but you don't have amendments. You were talking about how you were amending things within the bill, correct? Okay, so they don't have any amendments. It would only be Goodwill that has an amendment. What Lacey was referring to is how they amended the statute.
Okay.
Yeah, that's what it was. It got a little bit confusing for all of us, so we're good. Committee, are there any further questions? All right, seeing none, thank you.
Thank you.
All right, committee, you do have written only in support of the bill from Matt Fletcher, Interhab, Executive Director of Interhab. At this time, I don't see any more conferees on the bill, so this will close the hearing on House Bill 2751. We're going to go ahead and open up the hearing for House Bill 2750, permitting the use of expedited partner therapy to treat a sexually transmitted disease. And we'll give our reviser here just a moment because she's operating on a request that I just made of her. Let her finish what she's doing. Are you ready? Okay. Yeah, we'll have Revisor Moyer give us an explanation of 2750.
Thanks, Madam Chair. Jenna Moyer, Revisor Statutes Office. House Bill 2750 would authorize the use of expedited partner therapy to treat a sexually transmitted disease. It creates a new section of law. Subsection A defines terms used in the bill. Relevant to the committee may be the definition of healthcare provider, which would essentially be a physician, and then a mid-level provider, so a APRN or a physician assistant, and then it also has a definition of sexually transmitted disease, which would be diseases that are adopted as reportable infectious diseases under the authority in KSA 65118 and designated as appropriate for expedited partner therapy by the Secretary. Subsection B authorizes a healthcare provider who diagnoses a patient with a sexually transmitted disease to prescribe, administer, or dispense antimicrobial drugs to a sexual partner of their patient if, in the healthcare provider's professional judgment, the patient's sexual partner is unlikely or unable to be present for examination, testing, and treatment. The healthcare provider would be required to provide counseling to the patient, and there are other limits set out in the bill related to what the healthcare provider is required to do. And then subsection C provides civil liability for a healthcare or pharmacist if they were to act in good faith complying with this section. And it also, subsection D, requires the department to develop materials for physicians and mid-level, for those using expedited partner therapy to give to their patients to be distributed to the partners who are not presenting for treatment. And I will be happy to answer questions. Oh, and I should remind you that this was passed in the House in 2021. In 2022, it was heard in Senate Public Health and Welfare, and there's also an identical version of this bill, Senate Bill 404, that was heard in Senate Public Health and Welfare last week. Now I'll be happy to answer questions.
All right, thank you. Representative Orpeza. This is Orpeza Day. I like this.
Thank you, Madam Chair. Thank you, Revisor Moyer. Is there any limitation on the amount of partners, to say if you had multiple partners?
There's not, or thank you, Madam Chair, there's not a limit specified in this language. However, it would be up to the healthcare provider's professional judgment as well as liability.
Thank you. Thank you.
Committee, are there further questions? Representative Berquist.
Thank you, Madam Chair. As the discussion came about last time, and the previous representative mentioned numbers of partners, and the concern that I had was a sexually transmitted disease being known with one person and then being shared medication-wise, of course, for the health of the other individuals, but if there was activity going on with minors, sexual activity going on with minors, and they wanted to keep it under wraps, what would keep them from being able to get multiple treatments and being able to maintain as usual? And I'm not saying that exists in the state per se, but I'm not saying that it couldn't. So not so much a question to you.
Okay. Well,
But the question
provide
is,
a little context.
Is it not for the reviser? Or is it going to be for one of the conferees?
Probably, but it does, and the previous representatives got it clarified that it could be for multiple partners if the provider chose to go ahead and provide that. Is that correct? The treatment?
We're just on the explanation from the revisers. We've had no conferees yet.
Right. Thank you. I'm ready to wait.
Okay. Are there further questions of the reviser? Representative Clifford.
Yes. Was there a thought that there would be, provided this prescription would be held harmless if they weren't sure about the allergies of the partners, and then there was a problem?
Are you asking about the reasoning for the civil liability held harmless provisions?
Yeah. Yes.
That would be one possible reason. However, there would also be the check of the pharmacist who's filling this prescription. it would have to be in the name of the person who is being administered the prescription, so the partner, presumably, and they would be required to do their due diligence to check if that patient had existing allergies on file.
Okay, thank you. Thank you, Madam Chair.
Committee, are there further questions? Representative Burkham.
Thank you, Madam Chair. Page 2, subpart 4, it says a child who is 16 or younger may receive therapy when no parent or guardian is immediately available. What is there any idea what immediately means, or is that just kind of a broad term?
It's not a defined term, but it would just be the normal usage, not in the examination room.
Is that just up to the physician then to
Yes.
determine that? Okay, thank you.
Committee, are there further questions? Representative McDonald, and then Representative Bryce, I'm sorry.
I just wanted to clarify. He said in the subsection 4 on page 2, a child who is 16 years of age, he said or younger, but it's 16 years of age or older. That's a big difference, so I just want to point that out.
Are there further questions? Representative Bryce.
Thank you, Madam Chair. Thank you, Jenna. I just had a quick question. It mentions sexually transmitted diseases, and it mentions antimicrobials, which I assume would be antibiotics. And I'm wondering about viral, sexually transmitted diseases, antivirals. I was trying to figure out if this covers that, such as HIV, herpes, other viruses.
That would be a much better question for the physicians who I hope are testifying for me.
Okay.
I have a Juris Doctorate, not a medical doctorate.
Okay, that's very, very good. Thank you.
Further questions of the reviser? You look like you've got one, Representative Vaughn, no? Okay, just checking. All right, thank you very much, Jen, I appreciate it. Okay, we've got 5 proponents, and so if we can get through these quickly, I would prefer that you not read your testimony. Hit the highlights would be good. So coming in virtual, we have Dr. Derek Totten, Chief Medical Officer, Kansas Department of Health and Environment. Welcome to committee.
Good afternoon, Madam Chair. Can you hear me okay?
Yes, sir.
Thank you. Madam Chair, members of the committee, thank you for your time today. My name is Dr. Derek Totten. I am the KDHE Chief Medical Officer, and I am here to provide testimony in support of this bill, 2750, House Bill 2750. Briefly about me, can you hear me okay still?
Yes.
Thank you. Briefly about me, I am a lifelong Kansan, born and raised in Marysville. I attended KU Med for medical school, KU Med in Wichita for public health. My educational path was aligned with a couple legislative priorities, the Kansas Medical Student Loan Program, as well as completing family medicine residency at Smoky Hill in Salina, where they train family medicine physicians to enter rural Kansas. Since 2016, I've been practicing in rural Northwest Kansas, full scope family medicine with obstetrics in Colby. In Colby, I care for individuals affected by sexually transmitted infections and their partners, similar to many healthcare providers across the state of Kansas. Expedited partner therapy allows for healthcare providers to provide medication for partners of patients affected by a sexually transmitted infection, STI, without an in-person evaluation of the partner. EPT is certainly not a substitute for a full sexual health evaluation, but partners of infected individuals often cannot or do not seek treatment. This is crucially important for patients such as men who are less likely to seek treatment because they're less likely to have symptoms from their sexually transmitted infection. However, they can still spread the disease. Early treatment and preventing reinfection of diseases such as gonorrhea, chlamydia, trichomonas will help mitigate transmission to everyone affected, including newborn babies. A couple data points. Kansas data from 2022 shows a total of 13,967 cases of chlamydia, up from 11,138 the year prior. For example, gonorrhea cases have doubled over the last decade. They were at 2,237 in 2012, and in 22 they were at 4,995. Left untreated, these diseases can result in infertility, ectopic pregnancy, pelvic inflammatory disease, and rare circumstances, life-threatening sepsis. Compared to standard partner referral, EPT will increase the ability to treat partners in a cost-effective manner. Of the 47 states who currently allow a form of EPT, none have reported any major adverse effects, demonstrating the safety of this practice. Many healthcare providers in Kansas support EPT. The KDHE supports House Bill 2750 because it will allow Kansas healthcare providers another option to safely treat Kansans affected by these sexually transmitted infections. Thank you for your time.
All right, thank you very much. Committee, next we have Kelly Fritz, Miami County Health Department. Welcome to committee.
I'm a volunteer at the Miami County Health Department, and that's why I can speak. Thank you, Chair Landwehr, for holding this meeting and addressing this topic, and thank you for the opportunity to speak. I'm an APR and certified nurse midwife, and I've worked with moms and babies since 1985 as a midwife for the last 21 years. My career has been characterized by listening to women and taking care of their needs and their health care, and I'm here to speak for the women. I volunteered at the Miami County Health Department for over 18 years, first in the Family Planning Clinic and now in a limited scope Women's Health Clinic 2 mornings a month. I fully support expedited partner therapy as a tool to target and treat the women that I care for and help decrease infections and return. EPT is an evidence-based action. It is recommended by all of our national organizations, the American College of Nurse Midwives, the American College of Obstetricians and Gynecologists, and the American Academy of Family Physicians. And it is recommended nationally from the CDC for care for STIs. The physicians I've worked for and collaborated with my entire career have supported me in utilizing EPT, and they have utilized it as well. There have been no adverse reactions or complications in any of the practices that I've ever worked. EPT is managed by treatment guidelines regimens provided by the CDC and is offered when the provider can ensure that all of a patient's recent partners can or will seek timely treatment, and that's a big issue. Providing package oral medications as at the health department is preferred because many obstacles exist at the pharmacy level and many persons do not fill prescriptions provided to them by a partner. At the health department, education and instructions are provided in a welcoming environment without obtrusive or unnecessary questions that would be an additional barrier in the patient-provider relationship and decrease access of care. We ask about allergies. Pharmacies also ask about allergies. My goal is to increase the opportunity for testing, treatment, and health in the women in my community. And EPT is something that can reduce reinfection in my clients from their partners. We know that women are more likely to be screened. We're more likely to expect to go to an annual exam visit and have cervical cancer screenings and have an annual visit to get a prescription renewed for our birth control. Men are less likely to do that. Women are also more likely to will be getting screened during any pregnancy that they have. So women have more opportunities to get screened and be diagnosed. Young men are not accustomed to having annual exams unless they're on prescription medication and then don't have the same opportunity for routine screenings. They're less likely to have an established relationship with a healthcare provider. My female clients report that either their partners initially deny they could even be infected because they're asymptomatic. They're hesitant to find or see a new healthcare provider. They're afraid they're going to be swabbed. They don't have health insurance or they can't afford a doctor's visit. These barriers to care make it unlikely that they are going to have timely testing and treatment. Clients and partners ideally are treated and abstinent at the same time to decrease the risk of reinfection. EPT can help bypass those barriers, leading to immediate and concurrent treatment and decrease the spread of infection to others. In Miami County, Kansas, we have no obstetricians, gynecologists, CNMs providing maternity care, nor anywhere to go to have a baby. A lack of providers, specialists in women's health is a barrier to routine care and testing in Kansas. We have no family planning grant, which would provide free to low-cost services. We only have my limited women's clinic, which is not free because we have no grant funding. Attendance at this clinic is far below attendance prior to the loss of our grant. Cost is a barrier to routine care and testing. There are no OBGYN midwifery practices or places to deliver a baby from Overland Park to Pittsburgh. So you can drive through Miami, Lynn, Bourbon County, Anderson County next door. There's nowhere to go to have a baby. Nobody locally based that's a specialist in women's care. Distance to services and cost of travel is a barrier to care and testing. My county is not alone in this. 75% of Kansas counties have no maternity care services. No maternity services is a barrier to routine care and testing and treatment. The data we have concerning Miami County is concerning but incomplete. Local and systemic barriers to care and testing mean there's more cases out there than we know. COVID, March 2020, December 2022, decreased attendance to all healthcare visits and limiting opportunities for testing. We're still catching up on some of those services and screenings. Fewer people today have long-term established relationships with a provider or provider office than they used to. My family went to one family practice doc for 27 years until he retired. Today, providers change employment, change practice locations, or insurance networks more frequently. And today, individuals may change insurance companies frequently, affecting their available in-network provider options and continuity of care, decreasing their likelihood of getting care. Try anonymously cold calling a few private offices this afternoon, ask about their first available new patient appointment. I tried that last week for a 20-week pregnant lady who'd had no prenatal care, and my response was April 5th, 2 months out. She's going to be 28 weeks before she has a chance to get in to see somebody. That's unconscionable. These are all barriers to care, testing, treatment, and public health. In the face of all these barriers, expedited partner therapy can help us as one tool to have an impact on the increasing number of newly identified cases by reducing ongoing transmission and preventing reinfection of the original patient. Thank you.
All right, thank you very much. Appreciate it. Where's my notes? Oh, here it is. I got it. Then I've got Dr. Patrick Allen, Clinical Assistant Professor, University of Kansas School of Medicine, Wichita, coming in virtual. Welcome, Dr. Allen.
Thank you so much. Am I coming through?
Yes, we can hear you. Thank you.
Yes, thank you, Chair Landwehr, members of the committee. My name is Patrick Allen. I've been practicing family medicine in Wichita since 2011. One of my roles is training the next generation of family physicians for Kansas through the KU Wichita School of Medicine residency program. I'll bring up trafficking since one of the representatives mentioned that. We are very much on the front lines of combating human trafficking, and that's something that we are constantly looking out for and creating new policies to identify and combat. And to be clear, I think this bill could help us to identify, as we're asking about, what are your partner's names and dates of birth. We are mandated reporters, and whenever we encounter any suspicious activity, we do report that, and that's something that we're very proud and diligent to do. So I think this bill would help combat trafficking. I am here to ardently support House Bill 2750, protecting Kansas physicians and providers and their practice of expedited partner therapy. In my practice, I see gonorrhea and chlamydia daily. Those are the primary infections that we're talking about here. Viral STDs are not candidates for expedited partner therapy at this time. To answer another question, but I do like that the bill leaves that to the discretion of physicians, as there's ongoing research about which STDs are the best candidates for treatment with expedited partner therapy. For example, we're currently studying syphilis and trichomonas, and we don't have great answers for those, but we know that for chlamydia and gonorrhea, which are two of the most common and most morbid infections that we run into, expedited partner therapy is a wonderful tool. I do have one question for you. Have you ever told a young, healthy man with no symptoms to make himself a doctor's appointment? So I have, and it rarely works. So for whatever reason, partners often do not receive treatment, and that leaves my patients susceptible to reinfections. We see reinfection rates as high as 30%. That puts them and any of their unborn children at substantial risk, leading to things that I've seen include hospitalizations, surgeries, chronic pain, infertility, NICU stays, preterm deliveries, costly and really unnecessary complications for things that we could treat. As a social conservative, I want to be clear that I see this bill as one that values both women and their unborn children. This bill specifies that patient partners should come in for their own in-person evaluation whenever possible. Kansas providers will always strive for this whenever partners are agreeable. However, when they are not, we need to be able to employ EPT to help protect our patients from reinfection. Recent surveys show that nearly all Kansas providers support EPT. Even the most conservative and the most cautious of my colleagues think that this is something that should be protected. because we know from 46 other states that this practice is safe, it's effective. We know that states who protect EPT have slower rates of STI growth than states who, like Kansas, do not. We know that systems who utilize EPT have significant cost savings. For all of these reasons, I urge you to work this bill and to help us Kansas physicians and other providers adequately treat and protect our patients. Thank you very much.
Thank you, appreciate it. Then I have Kimberly Kern, Walgreen pharmacist. Is Kimberly with us?
Hi, good afternoon. Can you hear me?
Yep.
Thank you. Good afternoon, Madam Chair and members of the committee. My name is Kimberly Kern. I'm a pharmacist with Walgreens Specialty based in Kansas City. I do also serve as the pharmacist in charge of the Wyandotte County Health Department. Currently, I maintain credentials to the American Academy of HIV Medicine. The patient population that I serve is primarily HIV positive, so that has helped me better understand my patients. I'm here today to convey my support as a proponent of House Bill 2750. I do believe it will serve the population of Kansas in a variety of ways, helping to decrease the incidence of STIs by treating affected patients and their partners simultaneously. My biggest concern as a pharmacist who is patient-facing is accessibility to care. So things that can affect accessibility to care that I see are access to appointments, transportation, missed work days, cost, and health literacy. I think by removing the step of needing an in-person is we're able to bridge the gap, provide more accessibility, and reduce stigma surrounding STIs, in addition to reducing healthcare costs. Pharmacists have ample training and the ability to provide all necessary consultation required when filling prescriptions for EPT. I know over the course of my career, I've already seen numerous prescriptions for EPT. We can tell pretty easily when a prescription comes in what the indication is for, even without a diagnosis code. And I have had to turn specific prescriptions away based on how we would need to bill those prescriptions at the time they were written. So that's just causing a delay in care, which could then lead to reinfection, as we've discussed already. Pharmacists are considered to be medication experts, able to provide all necessary education as well as a non-biased interaction for our patients. Pending no known drug allergies or contraindications, EPT is safe and effective. And the more patients that can receive treatment, the greater overall benefit will be for the community as a whole. I thank you for your time, and I'm happy to entertain questions either now or at the end. Thank you.
All right, thank you very much. Next, I have Elizabeth, and I know I'm going to butcher this. Growing Way.
Oh, yeah, that was actually good.
All right, awesome. Wyandotte County United Government Public Health Department. Yeah. Welcome to committee.
Hello, thanks for having me.
Is the green light on?
Okay. Yeah, I think I'm just.
Yeah, you probably need to get a little closer.
I'm a little
Thank
short.
You.
Is that okay? Okay. I'm Elizabeth. I am the Chief Epidemiologist for Wyandotte County Public Health Department. And part of my job duties as an epidemiologist include tracking communicable and infectious diseases, looking for any concerning trends or things that we should be aware of as a possible concern to public health. And so one of the things that I've been observing as an epidemiologist is that we continue to see sexually transmitted infection rates increasing all across the United States, really, to the level that the CDC has declared STIs a public health crisis. And this is not just in the United States, but also Kansas has been impacted. We've continued to see STI rates in Kansas rise rapidly, nearly doubling in the last decade. And in Wyandotte County in particular, we've been hit very hard by STI rates. Wyandotte County has the highest STI rates of any county in the state of Kansas. And so as an epidemiologist, this is something that's very concerning to me and also impacts residents in Wyandotte County and across the state of Kansas. We've already had our physicians talk a bit about the health impacts of untreated STIs, things like infertility, preterm births, low birth weight, impacts for the babies as well as mothers. So I'm not going to touch too much on that, but did want to talk about how this bill specifically impacts reinfection, which is something that is really contributing to these rising STI rates. Where often a woman is diagnosed with an STI like chlamydia or gonorrhea and treated for it, but because her partner has not been treated, she becomes reinfected, sometimes multiple times. This is especially concerning for women and also if that woman were to become pregnant. And so expedited partner therapy really gives us a tool in the toolbox for our healthcare providers to help stop that reinfection from happening over and over again. And so the CDC states that expedited partner therapy is effective and safe for controlling STIs in communities. And in fact, Kansas is one of just 4 states that's not currently legally allowing expedited partner therapy. There's a lot of evidence and data to support this practice. 4 randomized controlled trials found that it reduced reinfection rates for chlamydia by 20% and gonorrhea by 40%. There's also been a population-level study done with states that legally allow expedited partner therapy versus states that don't, and found that, while all states are having rising rates of STIs, the states that legally allow expedited partner therapy only saw a 14% increase, while the states that, like Kansas, that do not allow expedited partner therapy saw a 17.5% increase, which is a significant difference in how rapidly STI rates are going up. There's also been an economic analysis done that found that EPT is a cost-saving and cost-effective action. So basically, you save more money by effectively treating a person right the first time by treating their partners versus allowing them to be reinfected over and over again, having to seek care and the cost of those prescriptions over and over again. As it's been touched on before, we also have a lot of support with the medical community. Both the American Academy of Family Physicians and the the American College of Obstetricians and Gynecologists support expedited partner therapy and have put out position statements in support. And then also, as part of my role as an epidemiologist, I conducted a survey across the state of Kansas, surveying Kansas medical providers, including physicians, nurse practitioners, and physician assistants. We surveyed 155 providers across Kansas and found very strong support for expedited partner therapy. Well over 90% of providers supported this bill and also supported expedited partner therapy and felt that it would help reduce STIs in their community. So in conclusion, I strongly encourage you to support this as it will make a difference in our rising STI rates. Thank you.
All right, Elizabeth, thank you very much. That concludes our proponents today. Committee, I'm not going to read through the list, but you can see that there's an excessive number of support by written only. And now we'll recognize one opponent, Nicholas, is it Reinecker or Reinecker? Reinecker? I mess that up every single time.
That's okay, ma'am.
I apologize.
No, it's a Reinecker, Nicholas Reinecker from Inman, Kansas. Thank you, Madam Chair and members of the committee for allowing me to speak today. I kind of feel like a voice crying in the wilderness. I am an opponent to this bill. I'm not a doctor, but when I saw that there were no opponents to Senate Bill 404, I did some research, including researching House Bill 2198 from 2019 all the way up to Senate Bill 404, which was heard last week. And so I felt compelled to testify. And I reject the idea that this is a pro-life bill. In fact, I say it is an anti-family bill that promotes promiscuity. And I know a lot of the testimony has been about persistent reinfections, and yes, these infections can have serious consequences. However, the only way to entirely avoid these infections is to just say no to any type of sexual contact outside of a long-term mutually monogamous relationship. And then there's other hygiene and unnatural affection issues. But the unsettling thing is that the proponent's testimony is saying that the current standard of care is now a barrier to care. So the chief medical officer for the Kansas Department of Health and Environment has testified that doctors seem to interpret the laws, and I understand that with telehealth there may be some blurred lines of legality, but I would think that this, the immunity part of this is not worth, the negative effects. Some issues that I have with this, it's been talked about these are bacterial issues, so if the statute doesn't limit other, like HIV or hepatitis B, you're just leaving that to rules and regs. I'm not really understand that. It's been touched on about the possible sex trafficking issues involving black market refills and issues like that, so I won't go into that. And then what about if somebody has a partner that gets a prescription, can they give it to a partner without them knowing it? Like slip it in their drink or something like that. So there's different issues like that. We've talked about the limited number, no limit of partners within the 60 days from beforehand. And basically, I just don't feel my taxpayer money, like if people are on Medicaid, should go to this type of thing. And it's interesting to note that from 2019 to 2020, there was a dip in infections, according to Kansas state data. So it appears that people weren't having sexual contact during some of that COVID time. The negatives with this, I think, is the government is actually optically promoting the deterioration of self-worth and mental well-being for especially like 16-year-old girls. And then what's great and tragic about this is then they will go and teach their children that this behavior is okay. Finally, Madam Chair, I would also like to say that as a man, we need more honorable men in this world to take care of women and to not take advantage of them. And if things happen, that they would make sure they deal with the reality, are accountable, and accept the consequences, so we don't need more crisis intervention centers. But I do not support this bill. You are the elected officials, you make the law, and we deal with the consequences. I will stand for any questions, and I thank you so much for allowing me to speak.
All right, thank you. And committee, you'll notice that I've gone out of order a little bit because of the number of conferees. I just thought we'd go through all of them, then we can ask questions of each of them. So that's the only opponent that we had, and I have a neutral from Susan Guile, Executive Director, Kansas State Board of Healing Arts. Welcome.
Oh, thank you. Executive Director of the Kansas State Board of Healing Arts. We are neutral on this bill. I think that most people would agree that treating a sexually transmitted infection earlier rather than later is probably a good idea. Our only issue is in some of the deficiencies, I think, that we see in the bill itself. I think the bill is vague in a couple of places. Our main issue is in medical record keeping. There is no requirement in the bill that says you have to have the name of the partner. You only have to treat what we're calling patient A, the person who comes to see you. And what the bill requires is that that patient is provided counseling and including distributing written materials to be given to the partners. And nowhere does it say that the names of those partners have to be given to the healthcare provider. So how are we documenting any information about those providers? How are the medical providers keeping records of that, which is a requirement of their license? So we're potentially putting these healthcare providers at risk of having a complaint about them for lack of medical record keeping. In addition, some of the things that have been talked about, oftentimes your providers are also dispensers, so there's not necessarily a pharmacy involved. So they may dispense the medication themselves, and then we don't know if any of these written materials are given to the partner. We don't know if they are being discussed about any allergies. Do they know if they have an allergy to penicillin? Do they know if it is a male that goes in and the partner is female, do they know if they're potentially pregnant or not? Have they had that discussion? If we have a female in a potentially domestic violent situation, maybe they don't want to tell their partner that they have an STI. Maybe they didn't get it from their partner and they're afraid. So maybe they are slipping it into their food somewhere and they don't know that they have a penicillin allergy. There's just too many unknowns, too many grays, too many things that I think need to be worked out in this bill before it could move forward. I think there's a lot of unknowns. Everything else I think is outlined in the testimony that we have, and there's been a lot of conversation about, young men don't want to come forward, maybe they don't have insurance, maybe they can't afford it. Those are all very valid arguments, very real concerns. but I don't think that we can let money be an excuse for poor health care. And I think that this runs the risk of poor health care for some of our constituents. So with that, I would stand for questions, and I thank you very much.
I appreciate that. All right, committee, do we have questions for any of our conferees? Please state the name, and then if you're going to get on the list for questions, let us know if it's the person up there so we're not doing musical chairs with our conferees. Are there questions, committee? Representative Bryce.
Thank you, Madam Chair. Susan, if you don't mind, I appreciate your testimony, your neutral testimony. And I'm a practicing physician, and I keep here. I'll tell you what bothers me about this is something you alluded to, I believe, is I can't think of any other scenario in healthcare where you don't meet the person, don't examine the person, don't talk to the person, don't keep a medical record on the person, and you prescribe. In any other scenario, that would be medical malpractice, or at least some disciplinary problem with the Kansas Board of Healing Arts. That's one. I want to reduce sexually transmitted diseases, but that's one thing that I have a little hiccup with this bill about. Did you have any comment on that?
I think that really, I think you provided my testimony better than I did. I think that's the crux of it.
Oh, well, thank you for the compliment. Thank you, Madam Chair.
All right, is the question for, anyone else have questions for Susan? Representative Reese.
Thank you for your testimony.
I couldn't find you.
The way you were presenting, you don't sound neutral. It sounded very much as opposed to this bill.
I am neutral on the intent of the bill. I think that treating a sexually transmitted infection earlier rather than later, if we can find a way to treat partners in a meaningful way as the bill intends, I think the board is neutral on that. We have concerns with the way the bill is written, where, as Representative Bryce just said, treating someone without seeing them, without knowing their name, without having a medical record, prescribing sight unseen without doing any sort of evaluation, knowing anything about that person, that's where the board has concern.
And how many times has anyone complained about being slipped, I don't know, penicillin or whatever, into their drink, that their partner unknowingly is being treated, was given penicillin to give to the partner? How many times? What's the data on that?
I wouldn't have any data on that right now, but also right now that would not be something that would happen because a physician has given it for that purpose in a legal manner.
Thank you.
Representative Barth, is your question for Susan? All right.
Sure. Chairman Langmuir. So I did have a few questions for you, and I would ditto everything that Representative Bryce also said. Those are concerns of mine, and actually then some. With everything that they can do and being in the medical field as well, I'm not a doctor, but this does raise a lot of concerns with sight unseen and providing services. When it comes to the Healing Arts Board and your normal duties with dealing with physicians who would be prescribing and providing materials, consult, things of that nature, is it typical to eliminate civil damages from a liability standpoint?
I've seen that in a couple of bills this year. I think I'm going to answer I don't know to that. I mean, I've seen it a couple times this year.
Okay. I've seen it too, but I guess I have concerns around that and would wonder if that concerns you all too, because typically, contracts are written and laws written to be bilateral. Both people have protections in the matter, and this gives no protection to the patient in that regard if something was done incorrectly or improperly. So that was a concern. So I didn't know if that, as a board, those are the types of things you review normally. Would that be a concern of the board, the Healing Arts Board, with there not being any liability charges for, if there were something brought to your attention on a board that would normally be reviewed, that would usually be in your normal reviewings, I think, right?
We looked at, so to be frank, this bill came up very quickly, and we got it last week. We had a board meeting Friday. We looked at it more for the medical issues, not so much for the legal parts of it, to be honest. But yes, I mean, yes, your point is correct.
Okay, so then the next point, so that was on page 2, C1, and then you go into 2, and it says that no healthcare provider or pharmacist shall, which is important because that means they must, be subject to disciplinary action by the State Healing Arts. They're not going to be subject to the normal things that you all would usually do. Instead, I think it gives it the power to the secretary for the Department of Health. So that doesn't seem typical or normal either to me, and something that would be going around the system. Would you agree?
Yes. So the way I looked at that was they would not be subject to disciplinary action for their acts related to this bill. There is still a requirement for medical record keeping, which is where I am coming at this.
All
So
right.
yes.
So there's a bunch of things in
Yeah,
here that are
and
not normal.
that's kind of my point, is I think this needs, if the legislature has an appetite to move the intent of this bill forward, it is the board's opinion that it needs a little more time. I think there needs a little more input and a little more work to solidify it so that it is, I think, a little more complete.
Thank you.
Representative Orpeza.
Thank you, Madam Chair. My question is, this has been instituted in 46 other states. What do those boards of healing arts do in regards to your concerns?
I've not been a part of drafting this, and so I don't know what the statute is in those 46 other states, so I can't speak to that.
Thank you.
Representative Vaughn.
Thank you, Madam Chair. Just to build on the former representative's comments, I did just pull up the law in Missouri, and it's written in a very similar way, where this is legal currently. As a neighboring state, have you heard of any concerns coming out of Missouri in line with what your concerns are regarding this bill? I guess that would kind of be my question, because I understand what you're saying, but I also know that it has passed in these 46 other states. In our neighboring states, it's written in a very similar manner. Based on the other testimony, we're not hearing a ton of other similar concerns. So I'm just wondering if you've heard anything coming out of neighboring states who have passed it, like Missouri.
I have not.
All right. Is there any other questions for Susan? Representative Berquist.
A little more appropriate time for my question. Sorry. Yes, ma'am. Thank you. The question is that if I want to get an antibiotic for treatment, I have to go to a physician, and that physician's under the Board of Healing Arts, and the ones that I go to anyway are under the Board of Healing Arts. And so these being under the Board of Healing Arts and dispensing medication to patients they haven't seen, it does seem, maybe it's helpful for some people because it may reduce the amount of STDs being spread, but isn't it difficult for a physician to be able to make an accurate dosage and instruction to the person if you don't see them? And you're counting on one person to tell everybody else how they're going to do it. One patient will give it to the rest of them, the other person or the other persons, and say, this is what you have to do. That's kind of the scenario in my head. Am I looking at it wrong?
That was the concern from the board.
Thank you, ma'am.
All right. Further questions for Susan? All right. Representative Clifford.
Thank you, Madam Chair. Quickly, what would the board consider to be the minimum medical record keeping in lieu of, you're not seeing the patient, so what would be the minimum? Their name, age, and no drug allergies?
So just generally speaking, under the reg right now, what it says is to be legible, contain only terms and abbreviations comprehensible to similar licensees, contain adequate identification of the patient, indicate...
Sorry to interrupt you. What would be the minimum? I see your testimony.
Okay.
Since you had this discussion on Friday, was there a thought to the minimal record keeping required?
We just referenced the reg, so we didn't speak really specifically to something like this. So I think we would need to have some conversation and dialogue around this specific topic.
Thank you. Thank you, Madam Chair.
Committee, further questions for Susan? All right, guess you're off the hot seat now, Susan.
Thank you. I do have a
very much.
245. Is it okay if I?
Yes.
Go? Okay, thank you.
Yes, you may. All right, committee, are there questions for any of the other conferees? Representative Epley and Representative Bryce.
Thank you. This would be for any of the, thank you, Madam Chair, and this would be, okay, I would pick
have to pick
Dr.
one.
Totten if he's still on with us.
Yes, sir.
I think you may be the expert to give us this information, and that is, we already alluded to this, that this similar language had been passed in 46 other states, but I would ask on one specific point that I know I've heard from several fellow legislators, is 16 years and older. Is that the way it is in all other states, to your knowledge? Is it 16 years and older, which, you know, is a little on the young side? And then also wanted to know if there were documentation issues or concerns that were raised here in other bills in other states. Thank you. Thank you, Madam Chair.
Thanks for the question. And actually, I have that it goes back as early as 2001, became more mainstream in 2006. When you look state to state, there is some small variation from state to state in terms of this state will make EPT available for gonorrhea and chlamydia. This state will make it available for those 2+ trichomonas. Some states will have it where providers will hand out quote unquote medication packets to the diagnosed patient to give to the partner. So there are little nuances like that in terms of when you're looking at the legislation from state to state and how this is carried out. And I'm sorry, was there another piece of that question?
Yes, Madam Chair, and yes, Dr. Totten, it was about the documentation necessary of the individuals that were receiving therapy. Is there anything codified in other bills, or rather in other states, on the amount of documentation of those partners and, you know, their background, their allergies, their weight, those types of concerns that I've heard around the committee here today?
Certainly, with the gonorrhea, chlamydia, and even trichomonas, when the treatment options are being taken into an account, they'd like to pick something that is an oral medication. They'd like to pick something that is the least amount of doses. In terms of a pregnant patient, they'd like to document if the partner is a female, so that you can choose a therapy that wouldn't interfere with a pregnancy, and so on. In terms of the documentation, because these are reportable diseases, they do ask identifying information such as name and date of birth at most locations. But in terms of if that's completely across the board, I wouldn't. I'm sorry, I'm not able to answer if that's exclusive for every state that's currently doing EPT.
Thank you, Madam Chair. Just based on your knowledge of this bill, it would be required in our bill that is before us.
I would like it to. So I like this bill mostly because one of the reasons I really like it is because it gives us the ability to then sit down and draft the appropriate policy for Kansas based on step one, passing legislation to let us make a policy for EPT. That would be my goal, would to be able to continue to have these as reportable diseases with identifying information such as date of birth and name and gender, et cetera, to help us with not just disease tracking, but also making sure that individuals are getting the appropriate therapies based off of their gender.
Thank you, Dr. Totten. Thank you, Madam Chair.
Committee, are there further questions? Representative Bryce.
Thank you, Madam Chair. Thank you, Dr. Totten, for your testimony. I had a quick question. I think you mentioned as examples of sexually transmitted infections, GC, chlamydia, trichomonas, primarily. As the bill is written now, it quote, any disease transmitted through sexual contact, unquote, and it refers to KSA 65-118. The revisor may have more information on that. But I looked that up, and basically I could find no limitation to, I mean, hypothetically, I mean, if I were devil's advocate, you could have lice. You could have, you could get COVID from having sexual contact with someone. You could have viruses, HIV, hepatitis. So the reason I bring this up is it seems like it's overly vague. Any disease transmitted through sexual contact. Would you be opposed to an amendment that would start out, say, with what you mentioned, GC, chlamydia, trichomonas, initially, and add to that as deemed fit, rather than having a wide open any disease possible transmitted by sexual contact? Thank you.
Yes, sir. That is actually, that is exactly what I would hope for in this situation, is that we would write the rules, regulations, and policy to go along with this bill that would support current expedited partner therapy knowledge based off of the randomized clinical trials and meta-analyses that have been performed. At the present time, most highly support GC, chlamydia, and that information can be extrapolated to also support trichomonas.
Thank you very much, sir. Thank you, Madam Chair.
Representative Epley.
Thank you, Madam Chair. And this wasn't a comfrey, but I would look to one of the proponents, probably, I would guess, probably Dr. Totten again, to answer this question about the bill passed in 21 was a more narrow bill, and it related only to, as I recall, chlamydia at that time. And I didn't know if you had memory or information on the bill that the House passed the House floor in 21. So it was a different bill, and wondered if if this language could be taken from that old bill into this bill. Dr. Totten. Thank you, Madam Chair.
If it's okay with the chair, I do have, I believe, Deputy Secretary Ashley Goss is in the crowd today, and she is here to help me 5 weeks into my role with a previous policy that's been passed.
Would that be okay? Yeah, Madam Chair said that's okay. Ashley, please, thank you.
Hi, thank you, Madam Chair. Ashley Goss, Deputy Secretary for Public Health. I need to reread that bill in full detail. I do think we could probably incorporate that language. It was only specific, as you recall, to chlamydia. So this bill offers a broader range, but as Dr. Totten has alluded, we would be open to the amendment, like your fellow legislator asked, to just narrow it down to that one or those three. I mean, it's not set in stone by any means.
Thank you. Thank you, Madam Chair.
All right, thank you. Committee, are there further questions? Representative Bueller.
Is Representative Pharmacist Kimberly Kern still on?
Yes, I am.
Kimberly, I have a question about, as a pharmacist at Walgreens, are there any with dispensing or providing medication? Does Walgreens have any corporate policies against that? I'm just kind of curious, as my wife's a retired pharmacist, if in thinking of what she went through and how she had to dispense medication, if there's anything from a corporate standing where Walgreens is either against this, or is there any effect in your ability to dispense this medication as a pharmacist if you're giving it to a person who's not the actual patient? That makes sense.
Yeah, so I haven't received any specific guidance as to that. I think the issue that we would need to identify, or my understanding is if this bill were to pass, then the actual regulation and standard operating procedure for providing EPT would then be developed. And so as that would stand, my perception is that there would be a patient-specific prescription, in which case we would need to fill a prescription for the intended patient. In this case, that would be the partner. Assuming that they had already received education at the doctor's office, we would then provide additional education at the pharmacy counter, either phone consultation, whatever would be best. But I think it is standard for pharmacies in general, as long as patient identifying factors are given at pickup, we are able to sell unless there's a patient request not to do that. But I don't have any specific guidance company-wide at this time.
Okay, thank you. Thank you, Madam Chair.
Committee, further questions? Representative Orpeza.
Thank you, Madam Chair. And I think this is for Dr. Totten.
Yes, still here.
Great, thank you. My question is the way I read this bill, it's completely optional, correct? So if the healthcare provider, doctor, NP, PA, would feel like it's not within their preview or they have some hesitation in prescribing to the partner, it's totally optional, correct?
I agree. Yes.
Committee, further questions? Representative Barth.
Thank you, Madam Chair. And this question is also for you, Doctor, as well. My question is, the section that actually currently says that there's no civil liability, if we said you did have civil liability, would you be okay with that? For treating a patient you've not seen?
I guess it would depend on a lot of, there's so many scenarios, especially in primary care and as a family medicine physician in terms of my comfort level from patient to patient, which is why it's good if something like that were included, that again, this remains an optional treatment method.
Okay, I think it's important that that's a good point right there, so thank you.
Committee, are there further questions? All right, seeing none, committee, that closes the hearing on House Bill 2750. We're going to see if we can make this work, committee. I would like to work the previous bill that we heard, which is House Bill 2751. Representative Epley.
Thank you, Madam Chair. I think the revisor is ready to hand out an amendment that is proposed on House Bill 2751 under 39, Section 209 on the bill, Section 3.
Open the bill first.
Oh, I thought okay. Sorry, Madam Chair, I'm getting the cart before the horse. I would like to move that we pass out House Bill 2751 favorably for passage.
Clifford seconds.
Second by Clifford. Discussion, well, wait a minute. First of all, committee, I need to ask, is there objection to working the bill? I forgot to do that. You have objection? Yes? What's your objection?
I still have questions that are unanswered in order to be able to work this bill. And I've reached out to some of the folks within the departments, as we did not have hearing from the provider side. We did not have testimony, from the provider side.
They had an opportunity to submit testimony and they chose not to.
I still object, but it's up to the
Okay, we'll
committee.
work it tomorrow, committee. All right, committee, we're going to turn our attention then. Let's see if we can do this. If not, we will do it tomorrow. What I've got to remind everyone, we are now on a timeline, and everything has to be out of this committee by Tuesday. About 10 bills were handed in to us on Friday, and it's my intention to hear almost every single one of those bills plus a couple of others. So we will be moving fast. You may also plan on probably being here on Friday as well. I don't like to do Fridays, but that's what it's going to take for us to get through in the time that we have allowed to us. So at this time, I'm going to open up working House Bill 2484. Chair recognizes Representative Epley.
Thank you, Madam Chair. I would like to move that the committee pass out House Bill number 2484 favorably for passage.
Seconded by Representative Reese. Discussion on the bill. Representative Reese.
Thank you, Madam Chair. Do you have an amendment? There was some discussion regarding background checks and regarding fees. So you're now being handed on 3 pages here.
Go ahead and explain.
I'll call your attention to page 2, which is line, it's under section 16, line 15. And the attachment A is the single sheet you received. That will be inserted there. This attachment explains the background checks and the fingerprinting that is going to be, that's going to have to be enacted. In order to apply for that multi-state compact, in the compact language specifies that if you apply for a multi-state compact, you must have a background check and fingerprinting. That's one, and you'll see that in this attachment. On the attachment that's sort of towards the middle there. But that also raised questions about existing social workers needing background checks. So most people get background checks through their employer, but we found out it is against the law for that employer to share that background check with the regulatory board, BSRB. So a separate background check will have to be done, and that will have to do, you'll have to renew that every 5 years. So new licensees would have to have that background check. Current license holders will need to do that background check at their renewal date. The next attachment, if you would, if you would, on that same page, you'll see number 3, you'll see where their fees that have been taken out. Yes, the first one is at line 23. There's one on line 28, another one on line 32. And then on the third page, we are inserting the actual fee for the compact, and that it shall not be more than $25 in addition to any other applicable fee.
Did you make a motion, Representative?
I make a motion that we approve the amendment.
Seconded by Representative Epley. Discussion, comments on the Reese amendment? All right, seeing none, Representative Deeb, you may close.
I close.
All those, motion made by Representative Reese on the amendment, seconded by Representative Epley. All those in favor signify by saying aye.
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 Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Back on the bill. What's your desire, Representative Epley?
Thank you, Madam Chair. I move that we pass out House Bill 2484 as amended favorably for passage.
Seconded by Representative Reese. You've all heard, is there a discussion on this? The bill as amended, did you say as amended?
I did.
Okay. I'm sorry, I'm multitasking here with other bills. All those in favor signify by saying aye.
I had some discussion, sorry.
Pardon,
I'm
Representative.
sorry. I raised
What?
my- You asked for discussion, and I had some discussion real quick.
Okay, what's your discussion, Representative Bart?
Okay, so, well, in general, I agree with this overall bill concept. I just haven't had a chance to read the amendment, and it's quite long and extensive. So I was just wondering if we could have just a minute to read through the entire page.
Go ahead, Jenna.
Thank you, Madam Chair. This is longer probably than the background check language that you've maybe looked at in the past, and that is because there's some changes in federal law where they have told our state that the way that we have been doing our background checks is not sufficient, and so there's actually a bill that was introduced last week that would add some of these additional provisions, and in order to be in compliance with the federal requirements for our background checks to go through, I had to add some extra language, but everything Representative Ruiz said was true, that this would require the board to require applicants and new applicants and those seeking renewal licensure to get a background check. And that would be a state and national criminal history record check. The multi-state or the compact licensees would be required to get fingerprints done. That paragraph 4 would allow, would specify the uses for that data. Paragraph 5 specifies that the KBI is required to release the information to the board in line with those purposes set out in 4. So essentially it's protecting the data. And subsection 4 specifies that law enforcement would be required to help and assist in taking those fingerprints. And then the KBI can charge a fee for doing that. And then the subsection D sets out confidentiality of those background checks, that if you're doing an open records request to the board, they would not be required to release the data from that information records request. And if they did disclose that information, this is in line with current practices. If information was distributed from those background checks, it would be a Class A non-person misdemeanor. And then just defining a definition of licensee and then adding it to the Social Workers Act. Hopefully that answers questions, and I didn't
Representative
talk too
Barth.
fast.
That does help. And I have had a chance to read through it now. Is there a fiscal note tied to it since there were changes with the amendments on the dollar amounts?
We don't have a new fiscal note and normally don't at this time.
Okay.
Further questions? Representative?
No, thank you.
Okay. Are there further questions? All right, seeing none. Representative Epley, if you'll move it one more time.
I close.
Is that good enough, Jenna? All right. All those in favor to advance House Bill 2484 as amended favorably for passage signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. All right, committee, that concludes our business that we have for today. We will take and work tomorrow. House Bill 2751. What's the other ones on the agenda? Do you have that, Dave? No. No, we're hearing bills. One bill. But we're going to work 2751 tomorrow is what I'm saying. I think there should be two of them. All right, what is that number? 2746 is the bill that we'll be hearing tomorrow. So committee, we are adjourned till 1:30 tomorrow.